So before we get started, I just wanted to share that today's talk is presented in proud partnership from all the different partners you see on the screen. We have the Histiocyte Association, the Histiocytosis Association of Canada, BMT InfoNet, the Immune Deficiency Foundation, Liam's Lighthouse, Eric's Journey, Be the Match, the SIJA Foundation, the Auto-Inflammatory Alliance, the HLH Heroes Foundation, Sobi Incorporated, Cincinnati Children's Hospital, Baylor College of Medicine, the Hospital of the University of Pennsylvania, and Children's Hospital of Philadelphia. And we've all come together to present today's talk, which is focused on HLH. And I am very excited to introduce you to your host for today, Dr. Michael Jordan, pediatric hematologist-oncologist with Cincinnati Children's Hospital. Dr. Jordan is the past president of the Histiocyte Society, scientific director of CCHMC HLH Center of Excellence, and the principal investigator for the INTO-HLH Registry, which is something we'll also be talking about today. So I'm going to say goodbye for now, and I will turn over the talk to Dr. Jordan, and let me just pass controls and we'll get started.
All right. Thank you very much, Deanna. I really appreciate the opportunity to speak to everybody. Appreciate the opportunity to and the collaboration and the help of all the groups involved. Let's see, I'm trying. Somehow I got muted here. Pardon me. Yeah, right. Okay, there we go. So, all right. So probably a lot of you in the audience have heard talks about HLH. And so I wanted to flip things on their head a little bit and focus on what do we not know about HLH. And I'm only going to be able to gloss over the surface because there are so many things we don't know. The purpose in this discussion is in part to also let you guys know about a new effort, which we're, initiating now and to really try to help fill some of these gaps. But I'll explain more of that in a moment. But just an overview of the things I have to discuss. So, I want to talk a little bit about what is HLH. So I know I have a mixed audience. Some of you guys know a lot about HLH, maybe some others not so much. And then we'll kind of focus on what some of the knowns and the unknowns by way of kind of compare and contrast. And then a brief discussion about how we can improve our understanding and ultimately the outcomes for patients with HLH. And then I'm going to shift gears a little bit and I'm going to talk about this new project, the INTO-HLH Registry. And then we actually have a pre-recorded video of me demonstrating how you could join the registry. So and that'll take about 15 minutes. And if it's not of interest, I'm warning you up front that that's, we'll spend some time on that. But hopefully, I think that you'll get something out of the first part of the talk if that's not of interest, and hopefully you'll be interested to participate because we really need everybody to work together ultimately to make real progress here. And then there will be some time for discussion and questions as well. So as you're putting things in, if I see things in the Q&A, sometimes I do, sometimes I don't. I'll address them if it's an appropriate time. Otherwise, we'll catch them at the end. Okay, so a little real basic background, right? So what does this name hemophagocytic lymphohistiocytosis actually mean? What is it telling us, right? So if you look at the first word, hemophagocytic, it breaks down into two parts, right? In medicine, when we say heme, we're really referring to blood. And when we talk about something that's phagocytic, it's really something, it's referring to a cell that's eating things. So what we're talking about is sort of blood-eating cells. And this word comes from what we see when we look under the microscope. One of the things that is somewhat distinctive, though not perfectly so, about patients with HLH is that when you do a biopsy of, say, the bone marrow, for instance, or other tissues, you can see these macrophages that are eating things in a very peculiar way. And that's where this term hemophagocytic comes from. This other word in the title of the name is lymphocytosis or lympho, right? And that means an expansion of lymphocytes, just like histiocytosis means an expansion of these eating type cells. And so when you put it all together, what it means is you have really too many lymphocytes, too many histocytes, and the histiocytes are eating things in a very peculiar way. And so, and these cell types, these are immune cells, right? And what is essentially happening is they're expanding into what looks like an angry mob. And this angry mob is actually what's causing damage to the patient's body. Now, in terms of another way to think about this, so what is HLH really, right? What are we talking about? What's the underlying process? And the simplest way I would say to summarize what is HLH is it's a dangerous syndrome of uncontrolled systemic inflammation, meaning it affects the whole body. And so if a normal immune response is like a small little fire, right, or something on your gas stove, right, HLH is more like a forest fire. So it's really massive and out of control. And it occurs because in many patients, we understand it occurs because there's normal feedback mechanisms that limit the size of immune responses, and these mechanisms appear to be broken in many patients with HLH. And by the way, a simple word about terminology, the title of the talk and what I'm referring to throughout the talk is HLH, but there are these other names, these are the disorders. So macrophage activation syndrome, for instance, cytokine release syndrome, these are referred to as by shorthand as MAS or CRS. These are disorders that really have the same pattern as HLH. They're seen in slightly different contexts. But really, I think that we should be thinking of them as all variations on a theme of the same sort of thing. And so I think of them as mostly HLH variants. And throughout the talk, I'm going to use the term HLH, but I'm actually really referring to all of these variants. Now, a little bit about sort of our how we got here, where we're coming from. So, in the early part of the last century, HLH was first recognized. By the 1970s, it was pretty clear to physicians. It was widely recognized, and it was seen in infections and malignancies, but it had a lot of different names. And by the early 80s, this term HLH was coined, and that's to help to sort of crystallize thinking. This other term, macrophage activation syndrome, was coined by the early 90s. So again, sort of recognizing the same sort of pattern. By 1994, there was an international trial, HLH-94, that was testing a standard new approach at that time, two drugs called etoposide and dexamethasone. By 1999, the first cause of HLH, genetic cause of HLH, was identified, and that's the gene perforin. By the early 2000s, the efficacy of this standard etoposide dexamethasone approach had been demonstrated. Around the same time, around 2002, the first experimental models of HLH were developed, and it was discovered that there really are sort of key players in the disease, that there's the important role for a cytokine called interferon gamma and immune cells called T cells in the development of the disease process. By 2004, the definition of HLH was sort of revised and updated for the second international trial called HLH 2004. Skipping ahead a bit, 2016, 2017, a number of immune activating therapies for cancers were developed, and it was noted, in the 2000s that these things cause this disorder CRS, which looks a lot like HLH. And by 2018, emapalumab was really the first drug ever approved by the FDA for the treatment of HLH, and it's now in clinical use. So when we think about HLH, when we try to make a diagnosis, I think it's worth remembering that HLH is a pattern, it's a syndrome, and it's often a real challenge for physicians. So we're looking, it's like we're hunting for a pattern, which can be mistaken for other things. This pattern is really comes from sort of expert opinion about what do young children with familial or genetic HLH look like. So it's really quite challenging. It's quite challenging to apply it amongst young children, but it's also challenging when you recognize that there are a variety of different types of HLH in this sort of familial HLH pattern, right? You see right here in the middle, the way we diagnose it is based largely on that. But we also know that HLH occurs in rheumatologic disorders where it's called MAS. It occurs in patients in whom we're giving drugs or medicines to activate the immune system. It's also seen in some patients with unusual immune compromise and unusually severe infections. It's also seen in the context of malignancies. And in some cases, we think that what we're looking at is something that is HLH that needs to be treated as such with immune suppression. And in other cases, it may in fact be things that look like HLH, but really may not benefit from being treated with immune suppression. So this is part of why this is a very tricky sort of diagnosis to make. Now, a brief listing of the things that we understand about HLH, how it develops, how we might recognize and diagnose it would be as follows. So, we know a number of genetic causes that are underlying for many patients with HLH. We know some of the sort of the key players in terms of immune sort of hyperactivation in these patients. We have a standard definition of HLH that's been in use for now a couple of decades. However, if you think about underlying causes, right? So there's still, in many cases, probably half of children, we don't really have clear genetic causes. And when we start looking beyond young children with sort of the more familial sorts of HLH, when we start looking in adults, we start looking at older children, individuals with these variants, including MAS. Very few of these individuals have an understood underlying genetic cause. We know when if the patients have an underlying genetic cause, we think that there has to be something that sets off the immune system. We'd call this a trigger. But even in the patients where we have a clear genetic understanding of what's going on, we only find triggers about half the time. So we're not really sure what's setting things off the other half of the time. And in patients that have sort of non-genetic HLH, or at least where we can't find a genetic underlying cause, we really have very little idea of how the immune system hyperactivates, how it gets out of control. So in terms of how we define or recognize HLH, there are a lot of things we don't yet know. So we don't really know how often the diagnosis of HLH is missed, or perhaps even more frequently, how often it's delayed. We recognize that it's a rare disease, and so it's not on the top of the mind for many physicians or even specialists, but we really don't have any sense of what's typical, right? Like what's typically happens when a patient is eventually recognized as having HLH. And so, we also don't really understand how often are we diagnosing things as HLH that in fact, probably in retrospect, at least, are not HLH. And so, this sort of understanding really is something I think it's really important for how do we improve this process, and including we don't really quite understand, what happens before somebody has the full-blown sort of manifestations of HLH. If perhaps we knew how this started, right, then we would actually maybe could be quicker in terms of diagnosing it. One of the things we actually know incredibly little about is we don't know how well the definitions we have for HLH actually apply to adults with HLH. So again, these definitions were derived from expert opinion about how to recognize typically infants with the disease, but we really, and we're sort of extrapolating when we apply it in these other contexts. There's been a lot of research in recent years, even recent decades, looking at new sort of more sophisticated immune tests to try to better recognize the disorder. But we really don't, these for the most part have not been well applied in clinical practice. And so we're still really at the very early stages of trying to apply newer, more sophisticated tests. Now, moving on to HLH treatment. And this is, like I said, this is a very brief summary of things we do and don't know. And so I think I could go on and on, but I think you get the idea that there are a lot of things that while we do have a good solid grasp of HLH, how it happens, how to recognize it in many patients, there are still a lot of holes there. And in particular, we don't really understand how well our definition of HLH works, which I think is really acutely important for patients with the disorder. So moving on to HLH treatment. So if I had to summarize, how do we treat HLH? We give immune suppression in order to sort of quench the fire that's consuming our patients. And then if the patient appears to be at risk for the disease coming back again, which would be true for anybody who has a genetic cause and probably for others, we're just not quite sure how many others, then the patients we need to give them a new immune system. And we do that with bone marrow transplantation. And with both of these modalities, then we can see a long-term cure. So how does our standard approach work? Well, here's some long-term data. So this is starting from quite a few years ago in terms of how this sort of combination approach works. As you can see, there's still a large fraction, in this report, about 40% almost, of patients that do not survive long-term. And this fraction of patients where treatment is not successful, it really is sort of a mix of patients that pass away before bone marrow transplant or after bone marrow transplant. And the reasons that they experience this are really probably different in each case. But I think that it's important to understand this. So now, what can we say are solid knowns and clear unknowns about treating HLH? Well, we know that standard therapy can work, right? Obviously, the curves we wouldn't have even 60% of patients surviving otherwise. But we know, of course, that treating patients with HLH is very difficult. And we know that, however, we know that despite these shortcomings, that patients treated, a number of patients or a large fraction of patients treated for HLH are thriving long-term, which is ultimately our goal. And we also know that newer drugs have come on the market in recent years, and even more therapies are being developed. As we have a deeper understanding of the disease, I think that we're going to see a proliferation of increasing numbers of options for how to treat it. But in terms of our important unknowns, so there are a lot of unknowns about standard therapy, and I'll just list several of them off right here. So we don't actually know how often patients respond to this therapy. While we have good data about how many patients survive, we actually don't know how well they're surviving. In other words, we don't know if the therapy is only sort of partially effective. We don't know how quickly patients respond. We don't know, and this is important because even though the standard therapy has sort of a template that we follow, it very frequently needs the intensity of this therapy needs to be increased or decreased. We don't actually know how often that's done in practice. And in addition to the standard therapy, as I mentioned, there's an increasing number of alternative ways we have to treat HLH, and we don't really have good information about how often these alternative treatments are used. So, that leads us a lot of uncertainty about how to evaluate the quality of standard therapy. Is it, how to optimize it to patients? Should we be using alternative therapies? We really can't answer most of these questions because we don't know so many basic facts about how patients actually respond to standard approaches. Also, in terms of improving, therapies for future patients, in addition to helping patients survive, we would like to make therapy better in many, many other ways. We'd like to not have patients experience serious complications, but we don't know a lot of basic things. We don't actually know how long patients necessarily need to be in the hospital or typically are in the hospital. We don't know how often they're typically in the ICU. We don't know how often patients with HLH experience really serious injury, things like organ failure, and which could be caused by the disease or could in fact be related to its treatment, right? Or sort of things such as life-threatening infections. So, and in terms of long-term data, we do have long-term data, and there have been publications, and that's why I can say that, patients with HLH, we know they survive and can thrive long-term, but these data really are limited, and so we need more to really be confident about what we have to say about long-term outcomes. And there are, in many ways, we really don't know all the things that we're potentially missing in a really global sense. And then finally, if we really hope to improve therapy or improve outcomes for patients with HLH, we really need to have detailed information about what we compare the new outcomes to. And this is challenging in a rare disease like HLH. It's actually extremely challenging to have a trial where you enroll patients where you might have two arms, for instance, where you might get the new therapy and an older therapy. And so we really need more information about how to characterize typical responses for patients with HLH in order to be able to make good sort of conclusions about future therapies that we'd like to be able to offer patients. So how can we fill these gaps, right? So we have global gaps about not only sort of scientific understanding of HLH, but really important gaps about how do we treat it, or how do we diagnose it at a practical level, and how do we treat it. And really what I'm referring to is information about, we don't know a lot of basic information about how patients respond to therapy. So it makes it more difficult to really evaluate future improvements, right? So how can we fill these gaps? Well, of course, there's always expert opinion. And this is a disorder in which there is lots of expert opinion out there. And it's usually based on the local experience of physicians and even, physicians such as myself and my colleagues here, where we end up conferring with and consulting with many physicians at other institutions. These data are still limited. And I think it's really important to note that even experts have biases, right? So we would like to work with real solid data instead of our opinions and our impressions. Now, a good way to get really rigorous, solid data is to do clinical treatment trials. Indeed, the quality of the data you get from these is often very good, but because they're very expensive and you typically need pharmaceutical company involvement, these are often limited or simply not feasible for the sorts of trials that we might want to do for the benefit of our patients. And then finally, in addition, in contrast with sort of treatment trials, there are observational clinical studies that can be done. And these are typically called registries. And by observational, I mean, you just sort of observe, right? You don't dictate how the patient is treated. You let the patient's physician judge the best treatment for that patient and simply record the outcomes. And this sort of approach can be comprehensive, but it's only effective if everybody, I shouldn't say everybody, if there's a large number of patients participating. But when you're talking about a rare disease, we really do need a large fraction of families and patients willing to participate in order to draw good conclusions. Because if there's a bias in enrollment, then we really would be limited in terms of the things we can conclude from the project, right? Now, I think it's worth noting there have been some past and ongoing efforts, I think I should really point out, and two of those are the international treatment trials that were sponsored by the Histiocyte Society. These were really groundbreaking trials, but it's worth noting that they really are not conducted like modern clinical trials. They weren't really as rigorous as a typical trial is these days. Much of the data collection was sort of voluntary, and so the data is very incomplete, and that's actually why much of this really basic information about how do patients respond to this therapy has never been published because the data simply haven't been gathered. Now, there were rigorous trials, conducted for testing emapalumab. That was necessary in order to get FDA approval. But it's worth noting the trial was, in the grand scheme of things, very small. And most of the patients that were enrolled in the trial were patients that had already been treated with something else before. So we don't know how well they reflect the typical sort of path of patients. So the data there are unfortunately still quite limited. There is a registry effort ongoing by the Histiocyte Society and ESID, and this has been going on for about 5 years. But by design, it actually has very limited data collection, and it's really not designed to answer many of the unknowns I've highlighted. And this is because it has very limited funding, and unfortunately, there's been really quite limited enrollment in North America. And this is these are all for practical reasons. And there is also a specific registry for adults with HLH. It's based in Germany, and there really aren't any centers that have opened it in North America. So it also is limited in its own way. So really thinking about how to fill these gaps, I'd like to introduce you to a new project that we have ongoing that we think is uniquely situated to help improve our understanding of HLH, so we have a solid basis upon which to improve therapies and treatments in the future. And this is another registry. It's called the INTO-HLH Registry. And by design, it's intended to be open to all patients with all types of HLH, whether it is familial HLH or macrophage activation syndrome in patients with juvenile arthritis, or whether it may be even forms such as CRS in patients receiving immune activating therapies. And we want to have it open to all kinds of patients because we want to be able to try to learn from as many patients as possible, but also to sort of understand the differences between these subsets. Now, the INTO-HLH Registry is also designed to be a very comprehensive registry. We want to get dense, detailed information about what happens to patients during their typical journey with HLH, specifically to try to answer some of these unknowns that I've highlighted already. So a few basic slides. So the objectives of this registry, as you can see stated right here, are specifically to understand more about how HLH develops and progresses, and investigate how treatment affects HLH. What are the outcomes, both short-term and long-term outcomes, including things like complications of the treatment or complications of the disease, and understand ultimately how it affects the quality of life and patients' lives. Now, what does participation involve? So this is the basic process here, is that with the consent of the patient or the patient's parents, if they're a child, we will collect the medical records from the time of HLH diagnosis and up to 5 years after, and then we meaning here in Cincinnati Children's, we will gather these records and we'll analyze them in a very specific process we've developed to pull out detailed information, to aggregate this information in our database to answer the questions that I've kind of already highlighted for you. We'll, in addition to that, we'll also, if people are willing, we have optional surveys where we'll ask, how has HLH affected your quality of life and affected you long-term from the patient's perspective, not just from the perspective of the medical records. Now, of course, if we're gathering patients' medical records, a very fair question we should always ask is how will this be protected? Because this is your private information. Of course, we're regulated by our institutional, our regulatory boards, and we will follow, we'll follow all of the sort of the regulations by the FDA and others, and including privacy regulations such as HIPAA or PHIPAA in Canada. The patient's data, in addition to this, the patient's data will be anonymized once we obtained it in our database, such that we don't really have to connect private information with the details of the HLH outcomes. And of course, as we aggregate the information from many different patients, that also helps to protect individuals' privacy. But over and above all of this, we have a staff that is professional and trained in how to respect the privacy and respect the importance of this in patient records, and they'll be maintained securely within, behind firewalls here at Cincinnati Children's. Now, I think it's worth noting that, as I already pointed out, with registries, they can be tremendously effective, but they really are only effective if we get a broad swath of patients in, participating, a large number of individuals from which we can really draw solid conclusions. And by sharing these data, by essentially donating your information, right, to the registry, by letting us sort of draw lessons from it, then we hope to, by combining this with information from many, many other patients, understand what is the typical journey, what are the hardships and the complications that patients experience, and what do we need to work on ultimately. Have real data, not just my opinions or my own experience, which may vary from someone else's, other physician's experience. And that we hope to take these sort of insights that we'll draw and ultimately improve the long-term outcomes for future patients. All right, so now if you're interested in participating, then we have, at this point, we have a video we'd like to show you that basically will show you exactly how you can sign up for the registry. And oops, let's see here. Yeah, so at this point, I'm going to hand it back over to Deanna, and she'll queue up the video here. And it takes about 15 minutes, and it'll walk you through our system.
In order to sign up for this registry, you'll want to first go to hlhregistry.org, or you can simply type in INTO-HLH into Google or your favorite search engine, and this should take you to our website here. On our website, we have a lot of good information for patients and families, physicians and researchers, etc. But we're just going to focus on this green button here on the right called Join the Fight. So if you click on that button, it takes you to this page where you see a few different options, including things such as learning more about the registry. But we're going to focus here on the this option on the left, Join the Registry. So you click the Register button, and here we'll ask you to provide a little bit of contact information. And this is really in case there's any technical difficulties with you signing up in our consent system. The consent system is separate from the website. So in case we need to be in touch with you about that, this allows us to do so. So we'll click the button here that says, Let's Get Started. And this will take you to the next page on our website where you'll see 4 different options. So depending on whether the individual in your family affected by HLH is yourself, an adult, or is your child and you're the parent, then you see different options. Additionally, if the person in your family affected by HLH is currently deceased, and you are the next of kin, then you can sign up on their behalf for the registry. So in each of these cases, whether you're signing up for yourself or on behalf of your child or on behalf of your deceased loved one, we will need your consent in order to proceed. And so you'll notice there's two different buttons for children, one for younger children and one for older children, that is 11 to 17. And the reason for that is, in addition to your consent to participate on behalf of your child, we'll also ask your adolescent child for their assent or their permission to participate as well. And so that's why we have two different sort of options there. But in this case, I'm an adult, so I'm going to click on adults 18 and over, so because I would presumably be consenting for myself. And we have two options here, whether you're in the US or in Canada. So I'm in the US, so I'll click on US patients, and it'll take you to a new screen. Again, this is outside of our website. So, and this is our consenting system, and you'll enter your email address. And when you do that, and you enter your email address, it'll successfully, it'll tell you that, please check your email inbox for a message, because the system will send a secure message to the email address that you just supplied in the previous screen. And it looks like this. The email says, you've been invited to participate in a study. And in that email is a unique link just for you, and sent only to your email address. And it's only good for about an hour. And this is, again, is to maintain security of the system. So once you ask to get into the, or say ask to look at the consent, you need to go ahead and click on that link within an hour while it's still good, so that you can it can take you to the consenting system. Now, when you do that, it'll take you to this first page, which is called Getting Started. And this page has good general information about the process. I'm not going to go over this information right now, because we're actually what's written on this page, because we're actually discussing things. So we're going to kind of go through this quickly, just to make this quick and efficient, a little faster than you'd want to do on your own. So I'm going to click the Continue button here at the bottom. And it'll take you to the consent document. Now, the consent document has several pages, which has important information for you to understand with regard to participating in the study. And we're just going to go through this quickly, just for demonstration purposes. And I want to show you at the bottom of each page, there's this little button, like a little ball here. You can slide it to the right if you still have questions after reading this page. And that'll sort of halt the process there, and it'll invite us to be in touch, or you can be in touch with us. But if you've read the page and you're satisfied and you understand, then just slide it all the way to the right, where it says, I understand. And if I can do this, it'll do that. Now, because I went through this page quickly, it also asked me to confirm, hey, you went through this pretty quickly. Are you sure you understand? And I say, yes, I do. And it takes me to the next page. You can change the text size. If the font size is too small, you can actually change it up here in that little button on the upper right here. And now you'd scroll down, read the whole page. Again, you get to the end and you say, yes, I understand. And this is asking for confirmation again. And again, the next page, there's information about the registry. And I'll just go through this quickly so we can get through the whole process here. And then finally, this page on privacy with detailed information about how your privacy will be protected. Again, I'll say, yes, I understand. And then there's this next page about authorizing use or disclosure of information for research. Again, sort of just general information about how the registry works and how the process works. And then at the end, I've gone through the 5 pages of the consent. There's this green line here. It says sign the document. So if you understand everything and you agree and you would like to participate, then you click on sign the document. For this, you need to put in your information. And so I'm going to just say, since this is a test subject, I'm just going to say my name is test, and just put in some sort of nonsense, information. I'll put in my email address. And then it also asks you if you'd like to participate in terms of optional questionnaires. These questionnaires are ones we would send to you about how HLH has affected you and your quality of life. And I'll say yes. Also ask you to initial here just to confirm the information that you agree with what you just put in, and then how you would like to be reached. And then there's this button, there's this field here that says tap or click here to sign. So when you click on that, you can actually, you're allowed to then, it lets you sign with your mouse. And so since I'm test subject, I'm just going to put in T. Let's see if I can do this without too bad of handwriting here. Test. Now, this is not the best example, I would say, but so there you go. And then you type in your name. So type in your full name that you just signed. And then once you do that, it actually, you can see here, it saves your signature and your name that you've signed the document. Now, in all the forms, it has this field for signing, but also for a parent to sign as well, even though this is sort of across all the forms, even though I'm signing as an adult. So I don't need to sign that form. I don't need to sign that field as well, excuse me. I only need to sign my own name as an adult. But however, and there's also a field here potentially for a witness or interpreter, but again, it's not something that we're going to ask you to do. It just happens to be a part of the forms. And then you say submit the signatures here. And then once you've done that, then you want to click on this other button that says read another document, because we have 3 different documents we'd like you to complete. So the first one is the main consent form. And that's already done. You can see the checkbox there indicating it's done. Then you go to the next one, which is the records release form. So signing up in the registry, first we ask you to consent to the research project, but then also specifically to sign a form that allows us to ask the institutions that where you receive treatment for HLH, or you or your child, for the records and the details around that treatment. So for this authorization, again, we'll say, I understand. And then click the button for this second form. It says sign the document. And again, I'll put in my information here as I'm test subject. I'll just put in sort of general information here. We do also require the last 4 digits of the Social Security number. And this is not really because we require it, because institutions that would release your medical records will require that information, as well as an address. And phone number. Again, this is all information that is required in order to obtain the medical records for studying. Now, the form will also ask you to put in the name of the institution that we would be requesting records from, and the address of that institution if you have it. If you don't have it, don't worry about that. Really, it's just the name of the institution. And so this form is just indicating that on behalf of me, Dr. Jordan, we're asking for your records, and you have to indicate, upon what basis, whether it's you or your child or your next of kin, that you're requesting the records. And then again, you'll see this sort of signature field, and I'm going to sign again. Of course, I'm signing that. There we go. And let's see here. So it didn't like how I put in my, I guess I signed it too much. Okay. I was not sure why it didn't like my signature, but it does actually. The system is very secure. And then I do submit the signature here. And then I go on to the next document. So this is why we say set aside a little bit of time. So we have the consent, the release form that allows us to retrieve the records regarding treatment of HLH for you or your loved one. And then the last form is really just an information form for us to make sure that we are getting the records from all the institutions that are relevant. And you see here, we have the hospital name. So we know we already asked for that, but sometimes an individual may have been treated at 2 or 3 or 4 different institutions. And so we want to make sure that we've gathered all of those different, institution names, and we don't, and we want to understand exactly, the name of the hospital, the city, and the state. And we have, fields here for up to 6 different hospitals, even though that's unlikely that we would be treated at that many places. We also would like to know the names and the city and state for the doctors that may have treated you or your loved one for HLH that were not in the hospital that you already listed for us. So for instance, if you saw somebody in private practice that was not at the hospital that you subsequently went to later for treatment, then we'd want to make sure that we got the records from that doctor's office in addition to the hospital, if it was separate from the hospital. So with that information, then we would like to also know when we ask for records, we need to know when what time period the records cover. So we'd also like to ask you, when did the HLH start? So we make sure that we gather the records from the correct time frame. In case there's, and just to make sure there's no confusion, then we want to make sure we know the full name. So the full name, the first, middle, and last name of the individual that who had HLH, as well as their date of birth. Okay, this is a little bit redundant, and we recognize that, but we just want to make sure there's no confusion about this individual. And so if you just put in that information, and then if you'd like to be contacted, you could tell us so. If not, and then don't check that box. And then we ask you to sign again for this form. And so I'm just typing test here because this is simply a test run we're doing quickly here. And then click submit signatures. And then you've signed this one, and it really lets you have the option to either print or exit. And I'm just going to click exit because I've gone through the 3 different forms. So the consent to participate, the medical records release to allow us to retrieve medical records, and then the next steps form, which gives us just a little bit of information to make sure we have all the information we need in order to get you or your loved one into the registry and start learning, from your experience. So after completing those forms, then it takes you out of the system. You can log back in. It will ask you for a password, and so it'll now, if you haven't set up a password, then you simply just click forgot password, and you can go back into the system if you need to get back into anything. But that really takes care of the consenting process. Hopefully that is a good explanation for how you can join the fight against HLH by joining the INTO-HLH Registry. If you have any questions at all, you can email us at the email address on our website. We have a phone number listed there as well. We'd be happy to talk to you more. If this electronic consenting seems daunting or you have any difficulty with it, there are ways that we can work through consenting via email or paper copies as needed. And so just be in touch, and we'd be happy to try to make this as easy as possible. Thank you very much.
Right. So, in summary, for this registry, right, it's easy to join, right? You could do it on your own time. You can go to the website and follow the processes I showed, but it is best to set aside a little bit of time. It's going to probably take 20 to 40 minutes to sort of do all this. And it's also probably helpful to gather a little bit of information ahead of time. The things I think I highlighted in the talk, in the video there, in order for us to be able to gather the information that's going to really help propel our understanding forward. So if you have questions about the registry, or you need any help, then you can email us at INTO-HLH@cchmc.org. The address you see right there. And Kay Coates, the registry manager, is happy to be in touch. You could also contact me directly at my email address. It's spelled out right there. If you just like to check things out, you can go to our website, which is hlhregistry.org, to check it out if you want to look around, and of course, follow the links as I showed if you would like to join the registry. Really just wanted to thank you for your attention. Thank you for your interest. And ultimately, we hope that by spreading the word if this seems like a good thing to you, then I would say tell anybody you know as well. By spreading the word, I think we will be able to hopefully mobilize the entire community to help make things better for future patients with HLH. And the way we do so is really study what happened to understand where we can make things better, right? To understand as best we can. And so at this point, I'm going to transition to answering some of the questions. There was a question about treatment for CNS HLH. And this is actually so HLH affecting the brain or the central nervous system. This is, I think, actually a very relevant question to the topic of what do we know and what do we not know about HLH. So we do know that about a third of children, young children that have, most of whom probably have genetic HLH, about a third of them have some evidence of brain involvement when they first present. But that with treatment with standard sort of drugs that are given systemically, that many of those patients improve. But for the patients that don't improve, part of what is sort of standard traditional approach is to give medication intrathecally, meaning into the spinal fluid directly. And I think it's fair to say that when you're dealing with brain inflammation, you'd rather be maybe overtreat than undertreat. But it's also true that we don't actually know how helpful that intrathecal therapy is. That's just one of the things that we say that we really don't know. It's something that we do because hypothetically it should be helpful, and we would rather overtreat than undertreat, but we don't honestly know how helpful that is. We do know that systemic drugs, etoposide, dexamethasone, things like that, that are given, and affect the whole body, can be beneficial, but we also know that in a substantial number of patients are not enough. And so we, I think the key thing about brain involvement in HLH is to actually look for it and to treat it if it's found, because sometimes we find that physicians don't quite recognize that they need to be looking actively for it and not just waiting for the patient to show us some sort of obvious sign of involvement. Let's see. I see another question that's in the chat about secondary HLH, and I think secondary HLH is an area in which there are even more unknowns than in the familial or genetic forms of HLH, in part because it's so varied. So the question was specifically, pointing out that the patient was affected by dengue, which is a tropical disease that causes very severe immune activation, and in some cases can really look like HLH, and the overlap I think is really quite striking. But the patient was treated only with steroids, and I think that's again, I'm no dengue expert because we don't have that here in the U.S., but that is quite typical from my understanding, but I can't really answer beyond that in terms of specifics of laboratory markers, because I really don't have the sort of personal experience, and I think the data that are out there are also quite limited. This would be an example of we don't understand how patients in many contexts, how exactly they respond to therapy, how well they respond, exactly what happens to the markers. So, and then there was one other question. I think this is with reference to the registry. So is there any limit to how long it's been since the diagnosis? There is no specific limit. We recognize that patients, for instance, that were diagnosed and treated perhaps more than a decade ago, that their experiences, their outcomes, and in some cases their treatments may be different than how we treat now. And so, our highest priority is to try to get the most recent patients, but honestly, we think we can learn from all patients. So there is no limit in terms of how far back we can go. It does become more difficult, in all honesty, if you get beyond 12 or 15 years, because the records are in often different forms with the transition, at least in the US, over to electronic records. But no, there's no limit in terms of how far back we're willing to take a look.
Thank you. And another question, Dr. Jordan, can families of deceased patients share their loved ones' data in the registry?
Yes, absolutely. And thanks for bringing that question up. For the registry to give us a really accurate picture of what happens to patients, we want to make sure that, as I mentioned, we want to enroll across a broad array, all kinds of patients. We don't want to only be speaking to the survivors, for instance, right? We don't want to bias our enrollment in this registry by only having some patients and not others. So it's actually, we have a process. It's quite easy and straightforward. Really, it's all the same sort of process. It's actually a bit simpler, unfortunately, if the individual is your loved one, whom your deceased loved one, who you're consenting for. But yes, absolutely. We think we'll actually have probably more to learn, honestly, from the patients that did not survive therapy. So absolutely, it's very important. We want to try to reach those individuals.
Thank you. And then there's a question, do secondary HLH patients need to take preventative antifungal medicine?
So that's a little bit difficult to answer as a generality. Antifungal medications are given to patients to prevent, obviously, the fungal infection because of the risk of the treatment itself. So it depends on how the patient's treated. If the patient's treated with etoposide and dexamethasone, then yes, antifungal medications are a good idea for the duration of the treatment. But because the secondary HLH can vary so much, it's a little bit difficult for me to answer that in a really general way.
Thank you. Can families or patients provide biologic samples to the registry?
Yes. So we are just sort of ramping things up right now. We are actually hoping to really work on that in 2023 to make our processes more streamlined. But we hope to be able to do that in an efficient way. But for now, I would say that yes, we are hoping to be able to gather biologic specimens, and we recognize that gathering biologic specimens along with data makes both of these things much more valuable in the sense that we can learn more when we have both.
Great. Well, thank you so much, Dr. Jordan. This was really informative. Really appreciate the conversation around the gaps in HLH and also the tremendous effort with the registry. There is a great deal of information on the HLHregistry.org, or you can also reach out.
All right. Thank you very much, Deanna. I really appreciate your help in terms of this event, and thank you all for your interest.